where you were sitting at home and giving the lecture and all. So I think this is the first unusual meeting I'm attending after a very long time. And nobody is also asked to talk about the causes which are beyond the usual causes. Well, this January 2022, if some of you follow tennis, you might have watched this match, the Australian Open men's final. Rafael Nadal versus Medvedev. This was an amazing match. Why? Because what was the score? Midway. Third set, two sets, Medvedev was winning. Third set, the score was 3-2, and he was leading in the fourth game 40. Clearly, he was all out to win, and as Dr. Trouble out here says that he was supposed to win. And artificial intelligence, it said 96% chances of winning for Medvedev. Everybody was already celebrating. But then this is a tribute to human grit, human intelligence, human unpredictability that Nadal won. The score was this. This was the 5-set. So clearly in life, as well as in clinical medicine, we see a lot of unpredictability and a lot of unusual stuff. But to go through the unusual stuff, first we also need to know what is the usual stuff. So I have 3 or 4 slides on what is the usual way by which you analyze a case of chronic diarrhea. Basically, you have to have 3 questions in mind, and these 3 questions have been taught from immemorial times, and I believe it would remain the same. That is acute versus chronic. Second question should be in your mind, functional versus organic. Third would be large bowel diarrhea versus small bowel diarrhea. The definition of chronic diarrhea has changed a wee bit in the sense that now it is more objective. You talk about stool frequency as well as stool consistency. And when you talk about stool consistency, you have a Bristol stool chart. So a Bristol stool chart score of 5 to 7 and more than 4 weeks of duration would tell you that the patient has chronic diarrhea. If the volume of stool is large, as there is no blood in stool, there are no rectal symptoms like urgency, frequency, tenesmus, and you have features of malabsorption like steatorrhea or excessive flatulence or protein malabsorption features, then it is small bowel diarrhea. Whereas if the stool has blood and has rectal symptoms are very much predominant, the pain is on the flanks, then you know the patient has large bowel diarrhea. Why is the reason that I still want to put up this chart today when we are talking so much about artificial intelligence and we are talking about third space endoscopy and everything? The reason being that this chart has stood the test of time, and today also this chart helps you to streamline your investigations very clearly. Because if you can make up your mind whether the patient has small bowel diarrhea or large bowel diarrhea, you can also decide the sequence of investigations. If it is a small bowel diarrhea, you do hemogram, biochemistry, you would like to do thyroid function tests, HIV, IgA, TTG, stool tests like for giardia, opportunistic infection, or a simple Sudan, stool Sudan 3 stain can be done. Endoscopy with duodenal biopsy and thereafter imaging is required in CT and uvula. If it's a large bowel diarrhea, then you would like to do sigmoidoscopy or a colonoscopy in addition to the basic blood tests. The common causes of small bowel diarrhea are celiac disease, tropical sprue, giardiasis, tuberculosis, Crohn's disease, small intestinal bacterial overgrowth and IPSID. We need to keep them in mind because if we are going to go to uncharted territories, then at least the usual causes should be very clear to mind. And similarly, the common causes of large bowel diarrhea would be irritable bowel syndrome remains the commonest cause, and then you have tuberculosis, inflammatory bowel disease, and colonic malignancy. Okay. So now let me take you through 4 or 5 cases which I have picked up from OPD, which we saw in last 1 year, which I felt may not be very exotic, but at the same time, each one of us had some learning points and were a little unusual. So this is a lady, 62-year-old lady who came from Shimla. She was symptomatic since 2019, loose stools, liquid consistency, large volume diarrhea and all without urgency. So clearly something like a chronic small bowel painless diarrhea. She underwent a CT scan in 2019 which was normal. She was advised upper GI endoscopy, but because of COVID she could not get it done. And thereafter she was on complementary medicine. When she came out here to our hospital in August 2021, she had a low hemoglobin, protein 3.8, albumin 1.8, and by that time she had got an IgA TTG done, so which was high, suggestive of celiac disease. So an endoscopy was done, which showed scalloping of duodenal folds. Duodenal biopsy was suggestive of celiac disease. She was started on gluten-free diet. She had partial response, but she did not respond over the next 2 or 3 months. So the question was what was to be done. She already had a CT scan 2 years back. So the question was it refractory celiac disease? Was it celiac disease going on to EAT cell lymphoma or something? So somebody went ahead and did a fecal calprotectin test. Although we were not clear why it was, whether it should be done or not. Fecal calprotectin test was high, and thereafter a CT enterography was done, which showed that there was terminal ileal thickening. Subsequently, colonoscopy showed deep ulcers in terminal ileum, and it was seen that this was probably a case of celiac disease with Crohn's disease, both diseases being quite common in our country, but this patient had both the diseases. So she was put on budesonide along with gluten-free diet, thereafter azathioprine, and she responded very well. So what are the two simple take-home points from this case? One is that if you are suspecting a case to be chronic diarrhea, then to have chronic diarrhea, then you avoid CT with positive oral contrast. This has been discussed in many meetings, but still many a times it does seem that we often make the mistake that CT abdomen with a positive contrast is so much easier to do. So one feels, let's advise that only, but you will miss out on some precious information if you do not do a CT enterography in such a setting or a MR enterography in such a setting and advise only a positive CT with a positive contrast. Secondly, fecal calprotectin is emerging as a valuable test. It helps to distinguish functional diarrhea from inflammatory diarrhea. Why so? In the sense that calprotectin is something which is a protein in the cytoplasm of the neutrophils. So whenever neutrophils get lysed, whenever there is inflammation, there will be a lot of neutrophil increase, and as a result, when neutrophil lysis occurs, the calprotectin gets released into the lumen, and so it will be picked up when you do a fecal calprotectin test. In other words, it is not diagnostic for any single disease, but it helps you to effectively distinguish inflammatory diarrhea from a functional diarrhea or an irritable bowel syndrome. So that way it will be very useful. But remember, it will not help you to distinguish tuberculosis from Crohn's disease. It will not help you to distinguish acute colitis, like infectious colitis, from Crohn's disease. Why? Because in both the cases, neutrophils would be released and lysed. So that is one thing we have to keep in mind. Case number 2, 31-year-old male, symptomatic since 2017. Again, long history of diarrhea, nocturnal frequency, jets of large volume diarrhea. The symptoms are quite progressive. He lost 20 kgs of weight and he was hospitalized also. So no prior comorbidities. 4 years history of progressive large volume watery diarrhea associated with pain, abdomen, as well as significant loss of weight. Hemogram was normal, TLC was normal, platelets were a little reduced, IgA-TTG was normal. HLA-DQ2 was positive, suggesting that the patient could be having potential celiac disease. Stool was done repeatedly, it was normal. Jejunal aspirate showed MDR pseudomonas, anti-HIV was negative. This patient probably went across the length and breadth of the country, so he had 4 or 5 endoscopies, including an enteroscopy, which showed some nodularity in the duodenal folds, nothing more than that. The repeated biopsies also did not show anything more, except that there was some amount of nodular lymphoid hyperplasia once trophozoites of Giardia was seen. Colonoscopy was done, which showed some nodules in the terminal ileum, and the biopsy was suggestive of again lymphoid hyperplasia. Malabsorption, other workup was done, and serum B12, folate were normal. D-xylose test was abnormal. Glucose hydrogen test was negative. So again, this told me that there's some amount of malabsorption. The point I want to make out here before I proceed further out here is D-xylose test is something which we really used to consider as a holy grail. Often when we are students, we used to swear by it, like, okay, D-xylose has to be done in a case of chronic diarrhea. But over the years, the practical relevance of D-xylose test has diminished considerably, and I don't think it is of much use today as such, except in a very occasional case. CT enterography done, nothing much significant out here. Fecal calprotectin was done, which was positive, again suggesting a little bit of inflammation, nothing more than that. It does not really tell you where you are. The patient, because he was actually DQ2 positive, he was considered potential celiac, put on gluten-free diet, and he seemed to do well, but again had a relapse, so remission, relapse, remission, relapse. Again, no set pattern emerging, nothing was emerging. Then a sharp senior resident saw the case. He saw the basic profile, the liver function test and everything. He looked at the profile, he just put down all the profile out there and then encircled something. He picked up the low globulin fraction all through. No major technology out here. It was just that he looked As we say that probably chronic diarrhea is the last bastion of clinical medicine, in the sense that here when you want to evaluate a case of chronic diarrhea, clinical medicine or clinical algorithms are still very, very important. Clearly it was hypogammaglobulinemia. He sent a serum immunoglobulin profile. It showed that IgG was low, IgM was low, IgL was low, suggesting that this patient had common variable immunodeficiency disease. That is why he was having persistent hypoglobulinemia. There was lymphoid hyperplasia. He had documented recurrent GI infections. That is why he was having malabsorption. These arrows was positive. That is why fecal calprotectin was intermittently positive. He was started on IVIG therapy and he is doing well. Case 3, 60-year-old female lady, no comorbidities, large volume painless watery diarrhea, day as well as night, duration 6 months, severe diarrhea requiring hospitalization, some amount of weight loss. All investigations done, stool routine normal, hemoglobin normal, albumin normal, HIV negative, thyroid negative, IgA-TTG negative, immunoglobulin levels done normal, D2 biopsy done normal, colonoscopy done normal, and CT angiography normal. So, what do you think was missed in this workup? What was missed in this workup was that when colonoscopy was done and it was normal, the biopsy should have been taken. Why? Because if you want to, this is a setting for microscopic colitis. So if you want to diagnose microscopic colitis, it can be only done if you take biopsies and not biopsies from only one segment of colon. You need to take biopsies from left colon as well as right colon. And you can pick up either the collagenous colitis or you can pick up lymphocytic colitis. Both are well treatable. So collagenous colitis will be picked up when you pick up the collagen band. Lymphocytic colitis if there are more than 20 IELs. Same case, if let's say even the biopsies are normal, how would you like to investigate it further? If the biopsies are normal, you would like to do a serum chromogranin level. Because some cases of neuroendocrine tumor would present as chronic diarrhea. So you would do serum chromogranin levels as well as proton of PET scan. Case 4. Drug-induced diarrhea, very, very important now. And another, I'm putting a setting out here, post-renal transplant diarrhea, because these are some cases which are often referred to us from nephrology colleagues, and we are at times in a quandary on how to manage. So this patient came, a 58-year-old male, renal transplant 2017. He was maintained on tacrolimus, MMF, that is mycophenolate mofetil, and he was a hypertensive on olmesartan, on metformin for diabetes, doing well 3 years post-transplant, and subsequently from October 2020 during lockdown he had diarrhea, and thereafter he continued to have diarrhea. So the immediate thing was, okay, fine, the patient is on olmesartan, and we all know that olmesartan is notorious for the enteropathy it causes. So olmesartan was stopped, but that did not help. So the next thing was, the next possibility was metformin. Could metformin cause diarrhea? Because the point in favor was 1/3 of patients who were on metformin may develop diarrhea. The point against was that he was on metformin for many years. So if he was on metformin for many years, can it still cause diarrhea after so many years and all? So as this paper suggests, that even in patients who are on metformin for many years, even 4 years later, they may have episodes of diarrhea. So metformin could still be the cause. So that is one thing. Second is MMF, mycophenolate mofetil. It is known to cause diarrhea. It's a known side effect, but again, after a long duration, whether it causes. The third is that obviously in this setting you have to rule out bacterial, parasitic and viral causes. All the garden variety causes which we know of, but generally CMV, Clostridium difficile are renowned in this setting and you would like to do that. So what was done in this case was metformin was stopped. There was no response. All tests were done. No test came out to be positive. All the stool tests which was done 3-4 times, they were all negative. CMV PCR was negative, EBV PCR was negative, immunoglobulin profile was negative, normal. He was treated with tenedazole, nitazoxanide, no response. Finally, we had a test with the nephrology colleagues because we wanted to stop MMF. The creatinine was 1.5. The nephrology colleagues did not want to stop MMF. They said, no, this is not because of MMF. And in the sense that we said, no, it is because of MMF, you have to stop MMF. So MMF was, the dose was reduced. But however, the patient did not improve. The nephrology colleagues tested us and we said all the stool samples are negative. We then took biopsies from duodenum and also sent microsporidia stool PCR which came out to be positive. The duodenal biopsy gave us the first signal because it showed that there was some suspicion for microsporidium, and the biopsy with modified trichrome stain was positive. And at that time also when we sent the stool samples were still negative. So the patient was diagnosed to have intestinal microsporidiosis. The nephrologists obviously, like, they had in the sense that they really won the war because in the sense they proved that we were wrong. He was treated with albendazole for 4 weeks, improved, and they showed us the literature also that whether it is infectious versus non-infectious causes. It seems that in post-renal transplant setting where the diarrhea incidence is very high, it can occur in the 64% of causes times it is infectious in origin. So even if your stool samples are coming negative, still your suspicion should be very high and you should continue to pursue that learning. And besides that, the immunosuppressive therapy and metformin also, they are known causes of diarrhea. Finally, another case, 23-year-old male, he was symptomatic from 8 years, 2013 he had fatigability, 2015 he had chronic diarrhea, endoscopy normal, colonoscopy normal, CT angiography showed multiple strictures out there, suggesting that this patient is also constructive disease, something which we call as tuberculosis or Crohn's disease, the major two differences. He was started on treatment for Crohn's disease. So initially there was some response, then again no response, he underwent resection, then infliximab was given, no response. The patient could not afford anything, so we put him on hyperbaric oxygen therapy because we have seen that it seems to have a good response in Splitzerine disease. Some response, had a second resection, then put on adalimumab. By this time, he developed tuberculosis because of continuous immunosuppression. He had to be put on ADT and steroids, but again, there was no response. In the sense that if you look at the hemoglobin values, they never crossed 10. If you look at the albumin values, they never crossed 2.5 or 3. He just continued to have some partial response with some symptoms despite being on complete therapy. So we did not know what to do in the sense that we had tried everything. He had a Stilton ball disease, young male, chronic Crohn's disease like phenotype, steroid, immunomodulators, anti-TNF, hyperbaric oxygen therapy, twice resection done. What to do? So we decided that this is something different and we sent his blood test for exome sequencing. Simple in the sense that this can be done at any place. This is outsourced. That there are a lot of labs in the country which are doing it, except that it is a little expensive. It costs somewhere from 18,000 to 30,000 rupees. So a blood test was sent, they sequenced it, and it was seen that the patient had SCL mutational gene which was mutated. This patient had a chronic enteropathy associated with SLC2A gene, which is a described entity which can behave something like Crohn's disease only. The only major difference is that it will not respond so well to whatever treatment we are giving for Crohn's disease. This is an entity where prostaglandin is increased, so the patient was treated with celecoxib as well as misoprostol. There was some response, partial response. Thereafter, we have been treating this patient with adalimumab and sirolimus, and he seems to be doing well. So final thing is that, again, COVID times. So whether COVID can cause chronic diarrhea. So this is a very recent data which I am showing you. That this is a case control study we just completed. 320 patients who had recovered from COVID, followed up for 6 months, and we had two control groups. One is the spouses who were COVID negative, and also controls who were not family members and who were COVID negative. And it was seen that at 3 months, around 37 or 11% of them had functional GI diseases, or in other words, around 5% of them had diarrhea. The diarrhea persisted for 3 weeks. It persisted beyond that 3 months. It persisted even beyond that for 6 months. And in fact, these islets were also positive in some of them, suggesting that as a post-infectious IBS, the same thing has been shown by Dr. Ghoshal initially, but that data is for 3 months. This data shows that for 6 months also the same thing persists. So, in the end, to summarize, when we're talking about the usual as well as the unusual, the usual way has to be known because you cannot forget the usual way. That is, we have to decide it is acute or chronic, organic or functional, small bowel diarrhea or large bowel diarrhea. Regular investigations have to be done like stool tests, IgA, TTG, HIV, thyroid profile. I did not talk about Clostridium difficile in detail because in the sense that generally causes acute diarrhea and it's more a recurrent diarrhea, it's more in a hospitalized setting, but otherwise stool tests can be done. 2-step stool tests should be done, GDH as well as Clostridium difficile toxin. CT angiography should be preferred over a positive contrast CT. If you are going to endoscopy and colonoscopy would be required, but if you are doing a colonoscopy, even if it is normal, do take biopsies left and right side. Fecal calprotectin is a good adjunct test. Remember, drug causing diarrhea is causing a major proportion of chronic diarrhea today. You should be aware of it because of polypharmacy. Serum immunoglobulin globulin profile can help in certain places, chromogranin can help. And if you are really stuck against the wall and it's a young patient, it may be prudent to send a genetic profile, although the chances of getting it positive are low, but yes, in some cases you will. Thank you so much very much.
Most of the patients who are having the chronic diarrhea, as I think you have lightened the how to diagnose and how to take care of the patient, and the forum is open for the question, but as paucity of time, only one question is allowed. So certainly Charles has got this opportunity.
Talking about fecal protein test for last more than a decade, but one question which still remains is, what should be the cutoff above which is supposed to be abnormal or normal? Because these values are always varied with different labs. What would you suggest? If beyond this it is certainly abnormal, less than that, dicey.
250, if you take a cutoff of 250, then your specificity will be much more. If you take 150, then the specificity would be a little less, but anything above 150, you should become suspicious that okay, there is something out there in terms of inflammation. If it is about 250, then definitely something is there.
And in your workup of a small gut diarrhea, do you have the previous test of calculating osmotic gap and all these things still exist, or it doesn't?
They are relevant, but in very, very few cases. In the sense that any investigation which is not widely available, I think my logic is that I have not put up 3 tests, if you would have realized. One is I didn't talk about these others, because it is not widely available. That means it is not so. It's not a practical test. Second, I did not put up fecal elastase, because if you have done a CT already, then that will tell you. I did not put up hydrogen breath test. Most of the time these patients have already come with antibiotics, so it does not help. As it is, the sensitivity and specificity of hydrogen breath test is poor. Whereas rest of the other tests, they would have some value here or there. I did not put up 24 hours fecal fat test, because it has less value to them. You do a Sudan stain 3, and that will give you an idea whether the patient has fatty.
When I came back about 30 years back, no pathology was ever ready to do that grinding because fecal fat, nobody is doing it.
And still nobody does it.
Polypharmacy, diabetic, receiving metformin, olmesartan, and then atorvastatin, all added together. So, which drug would you like to stop first if the patient comes with diarrhea? Because this group of patients, they are already on multiple drugs, and you can implicate all. You also have PPI with that.
One by one. That's the only way.